All right, good evening everybody and welcome to French Theater on Town Hall number 3 for our Ebola virus disease information briefings. My name is Joe Peak. I'm the Joint Base Lewis McChord Installation Public Affairs Officer, and for all of you that made it here this evening, thank you for braving the cold and coming out for the information. Just a couple of quick notes. Lieutenant Colonel Rod Markham from Madigan Army Medical Center is here. He'll be doing most of the briefing up front here. After he does his briefing, we'll open the floor up for questions. So if you have any questions, you're welcome to come here to the microphone right here in the middle aisle, walk up, and you can ask your question. Just so you know, we are streaming this live over the internet. We've been doing that for the other town halls for people who aren't like you and brave the evening cool or the daytime. So they'll be able to watch it, and then also at the end of the week we'll be putting links to all 4 of the town hall meetings up on the Joint Base Lewis McChord Facebook page. And I think I've hit all of my important messages, so with that I'm going to turn it over to Colonel Chuck Hodges, Joint Base Commander.
I just want to reiterate thanks for everybody for coming out this evening. And what is tonight's all about is purely education and information. And so Colonel Markham gives a fantastic briefing and orientation, and then we open it for questions. So I want to encourage everyone, especially we have a small, intimate group here, to ask all the questions you want to ask. So when you walk out of here, you feel fully informed, fully aware of everything that's going on, and there's not any doubts in your mind in terms of what Ebola is and what's going on here on Joint Base Lewis McChord to support it. So, without further ado, the expert, Colonel Markham.
Thank you, sir. Everybody must have heard that I was speaking tonight and decided not to come. No, on behalf of the senior leadership at Joint Base Lewis McChord, the hospital commander, Colonel Fiore, and the entire Madigan healthcare team, I want to thank you guys for taking time out of your busy schedule this evening to join us in a discussion about Ebola virus disease. So, my name is Rod Markham. I'm a preventive medicine physician at Madigan and the hospital's public health emergency officer. And in that capacity, over the past few weeks, I've been involved with a large team working to synchronize our Ebola response efforts with those of local and state public health authorities and to make sure that our plans jive with what the Department of Defense and the Centers for Disease Control has put out so far as guidance. What I'd like to do this evening for a few minutes is summarize some of the key aspects of Ebola virus and its disease in humans, introduce you to some measures that are preparing and protecting our service members that are deploying to West Africa to support Operation United Assistance. I'll highlight what Madigan has done to prepare the facility and its staff in the unlikely event that we have to take care or diagnose an Ebola virus patient. Then lastly, talk about what we can do moving forward. So since its discovery in 1976 on the Ebola River in the Democratic Republic of the Congo, the virus has led to about 20 to 24 small outbreaks, or what we call clusters. These clusters had occurred in Central Africa, an area that is a region that's very sparsely populated. It's largely inaccessible with very small numbers of villages and groups. And because of that, most of these outbreaks didn't get very large scale and they didn't jump between villages. Around 7 months ago, we saw cases for the first time in West Africa. And that's significant because West Africa's infrastructure is much more robust. There's a lot of roads, there's a lot of transportation options, and most concerning, there are bigger, more densely populated urban centers. And so over this subsequent 7 months, unfortunately, we did see cases enter these major urban centers. And as a result, this has become the largest outbreak that we've seen to date. Fortunately for us, though, Ebola virus does have, sorry about that. So being the biggest outbreak to date and being a distinct hazard, we are lucky in a sense, though, that there are some vulnerabilities of the virus. And the greatest vulnerability of this virus is the fact that it is very difficult to transmit between humans in routine casual interaction. In order to get infected by the virus, you have to have direct contact with an infected individual and symptomatic individual's blood or body fluids. And that contact has to occur on skin that isn't intact. It's either broken through a cut, scrape, or abrasion, or through an unprotected mucous membrane, so places like your eyes, your nose, or your mouth. The Ebola virus itself is not transmitted through the air like a common cold or the influenza virus, nor is it transmitted through the bite of mosquitoes or other insects like fleas, ticks. And it is not transmitted through the consumption of routinely available food or water sources. And a great example that we can look to for just how difficult this virus is to transmit between humans is within our borders here in Dallas, Texas. There was a gentleman that came from Liberia after having some very high-risk exposures while he was in his home country. He came to Dallas, he stayed with family of 4. They were relatives. They lived in a small apartment. About 5 or 6 of the days he was there with that family in this apartment, he was suffering from pretty significant symptoms as a result of Ebola virus. And he had nausea, vomiting. He was also experiencing diarrhea. And the great outcome in this, if there is any, was the fact that those 4 individuals that had very close contact with him did not subsequently go on to develop Ebola virus disease. And I think that's important to understand, and it speaks to just how difficult it is to transmit from human to human through routine casual interaction. Now, Ebola virus disease is a very serious illness. To date, there are no FDA-approved vaccines or therapeutic regimens, things like drugs. There are a number of experimental agents and great vaccine candidates, but to this point, all we really do and what we really rely on is early and aggressive supportive therapy. And that supportive therapy takes the shape of rehydration. So we give them as much fluid as they can tolerate to replace anything that they lose, preferably through the mouth, but if necessary, we'll give them supplementary intravenous fluids. We monitor and replace their serum electrolytes, their blood salts, if it's required, and provide them with supplemental oxygen if that's necessary. So that top bullet on this slide is one of the very salient points that I hope you take home from our discussion today, and that's the fact that there's a very small subset of our population that is at risk for developing Ebola virus disease. That small subset of our population are individuals with an appropriate travel history, meaning in the last 21 days, they've traveled to one of the 3 countries that still have transmission risk. Those 3 countries are Liberia, Sierra Leone, and Guinea. So once a person has that potential Ebola risk, we look for symptoms. Another vulnerability of the Ebola virus is the fact that it's not transmitted unless the individual is symptomatic, and we take that to our advantage. So we identify that small subset of the population that is at risk as a result of their travel, and we look for their symptoms. One of the challenges, however, is the symptoms that are common for Ebola virus are also common for many other infectious diseases that people traveling to West Africa might encounter, things like malaria or dengue fever. And then also, this time of year in the Northern Hemisphere, we're also faced with seasonal influenza, and many of those symptoms are shared between it and Ebola virus. The common symptoms include a low to mid-grade fever, headache, people often complain of body or joint aches, fatigue, weakness, oftentimes leading to stomach discomfort, and then developing nausea, vomiting, and diarrhea. And so as a clinician, we take great effort to try to identify that small subset of the population that is at risk and determine if that risk is associated with any known symptoms to make a decision as to whether or not the individual is at risk for having Ebola virus disease. So Operation United Assistance, this is the Department of Defense's supportive effort to other governmental organizations, and in this case, specifically USAID and other non-governmental organizations to help build capacity at the very source of this outbreak in West Africa. There are no DoD service members that will provide direct care to a known Ebola patient, and that's important in understanding the exposure risks for the deployed service member. Additionally, every effort is being made to reduce the overall exposure risk to any and all service members deployed to the area. So what we do before an individual deploys to Operation United Assistance is we provide them with some pretty extensive briefs on the health threats common to West Africa. Examples of those health threats included the environment itself. It is a tropical region. Temperatures right now range from the upper 80s to low 90s with very high relative humidities. And And all of us today can appreciate how uncommon that is right now in the United States, and certainly in this area. So the environment is a risk. There are a lot of vector-borne diseases, and by vector-borne, I mean mosquito-borne. So we instruct them on proper protective measures to prevent mosquito bites and subsequent infections like malaria or dengue fever. And we spend a lot of time talking about Ebola virus and the key health protection measures they can take to minimize their risk of potential exposure. We introduce them to the monitoring that they're going to experience while they're deployed. And that monitoring is a twice-a-day health check. Basically, they come in, a trained medical professional will take their temperature and ask them if they have any symptoms that might be concerning for Ebola virus and make an overall assessment of their risk that day. And lastly, we provide them the opportunity, a hands-on chance to practice with their duty-specific personal protective equipment before they deploy. Nearly all service members returning from Operation United Assistance, when they return, will undergo a 21-day controlled monitoring period. During that 21 days, basically, we'll continue that same level of monitoring that they experienced while they were in West Africa, do twice-a-day health checks, continue to make sure that their temperatures remain below the 100.4 threshold, ask them about their symptoms, and then after they complete that 21-day period, they'll be redeployed to their home station for completion of redeployment and then ongoing to the reintegration process, excuse me. I said nearly all because there are some service members whose exposure in country is so small that they actually don't go through the 21-day controlled monitoring. Rather, they go through a 21-day self-monitoring plan in coordination with their unit medical representatives and public health authorities. A good example of that would be the air crews flying missions, providing support in country. So Madigan is ready in the very unlikely event that we have to or ask to evaluate, potentially diagnose or treat a patient with probable or potential Ebola virus disease. The hospital, its medical and dental outlying clinics have instituted universal travel screening. We've trained frontline clinical and clerical staff on the signs and symptoms of Ebola virus, the initial actions necessary if somebody screens positive at that first contact. Each site has dedicated isolation and segregation areas where a patient that has an appropriate travel history can be escorted to and be asked some additional questions. Each of those locations has the proper personal protective equipment necessary to conduct that screening. In the event that somebody does require admission to our hospital, we have over 60 individuals, allied healthcare team members that have been trained, of various types of nurses to various physicians, some clinical support staff and operational support staff that can provide that very important early and aggressive supportive care, manage the regulated medical waste, all of this in very high levels of personal protective equipment. So this slide is my cue to kind of introduce the fact that we're entering a new phase of our domestic Ebola response. It's been, since last Friday, it's been over 22 days, which is the longest duration for the Ebola virus's incubation period. It's been 22 days since the CDC established very rigorous screening processes for all individuals coming from one of these countries with ongoing transmission as they enter the United States in one of 5 airports. And so what that means to us in the community and even in the healthcare environment is that we now have a very good idea of any and all individuals, that small subset of the population that has a risk for Ebola virus disease. We identify them, we screen them, and then we conduct a handoff to the location that they're going to be for the following 21 days and do active daily monitoring. So each individual is then, they touch base with the public health authority on a daily basis. And so it's much less likely that we'll see another individual come from a country with endemic transmission and develop symptoms and unwittingly or unknowingly expose others to the disease itself. So what we can do together as we move forward in this new phase of our domestic response is if you have that appropriate travel history, that 21 days to Sierra Leone, Liberia, or Guinea, continue the dialogue with your public health authority. If you haven't had that dialogue to this point, reach out through your primary care provider, pardon me, or as you'll see in the next slide, reach out to Joint Base Lewis McChord's public health or preventive medicine assets and we will go ahead and begin that monitoring process and discuss with you your potential for Ebola virus. Also encourage those that you may know that have a similar travel history to do the same. If you're unable to or uncomfortable working through your primary care manager for this, we can be reached through the TRICARE Regional Appointment Center during normal business hours. Just identify your travel history and that you would like to speak with a preventive medicine representative to discuss your risks. And in after hours, our main hospital line is also able to reach out and link you to preventive medicine assets here on Joint Base Lewis-McChord. So that's really what I hope to present to you today. I think a couple of key points to take home. Transmission is difficult between humans in routine casual interaction. The high-risk individuals, or that subset of our population that is at risk, has a travel history in the last 21 days to one of the 3 countries. We can treat through early and aggressive supportive care. And if you do have concerns or questions and an appropriate travel history, by all means, at your earliest convenience, please reach out to Public Health or Preventive Medicine Assets, and we'll discuss your concerns at that time. So at this point, I'm eager to hear some questions. I think this looks like a very excited crowd that has lots of questions that wants to try to stump me. Because it can be done. It can be done for sure.
Good. Thank you, Lieutenant Colonel Markham. If anybody here has a question, you're welcome to come forward to the microphone, and either Lieutenant Colonel Markham can try to answer your question or a member of the command who is here this evening. Does anybody have any questions? Or if you have a question and you just don't want to come up to the microphone and ask it, you're welcome to hang around here afterwards and ask the question. The information that Lieutenant Colonel Markham has provided here tonight is very important, very informative, and we do have one more town hall scheduled here in this theater tomorrow at 1 p.m. So if you have any friends, colleagues, not 1 a.m., if you know anybody that you think ought to come here and listen to this information or watch it online, let them know. So any questions going once, going twice? Oh, yes.
I read in the Northwest Guardian that one of the quarantine areas for returning military members is going to be on North Fork, and I just wondered when they might start returning. When might that quarantine begin?
Yeah, where now we have not been actually designated. I mean, we've been identified as one of the 6 locations that will be one of the monitoring sites, but we haven't been given the actual direct mission of receiving service members back. The earliest possible date from when we've been given is the 21st of November is the earliest possible date that we could potentially be receiving those back there, but we haven't been given that mission yet that they'll be coming here.
Building on what Colonel Hodges said, I'm Colonel Oshiki, I'm the First Corps Surgeon. Building on what Colonel Hodges said, and to answer your question, this is not a quarantine, and we don't use that term for a very specific reason, because the soldiers come, like Lieutenant Colonel Markham said, the soldiers that are coming back from West Africa, and airmen and Marines and anybody who's going to be in our controlled monitoring area is at very low risk for contracting the Ebola virus disease. When we quarantine someone in the medical world, that has a very specific meaning, and it's when somebody does have a disease and we're separating them out from the population in order to protect others. In this case, these soldiers do not have a disease. They are not being quarantined. And if they were, by the CDC guidelines, if these individuals were coming back from West Africa and were in the civilian community, they would be at home monitoring themselves. So the DoD has taken a very conservative approach to this and is being very deliberate and very scripted in our response to take the most careful possible approach by monitoring our soldiers, sailors, airmen, and Marines, and DoD civilians in a controlled environment that is separated from other areas, but it is not a quarantine by the medical definition, just to clarify that.
Thank you, sir. That's the same question that came up yesterday. So that's a very, very important differentiation between quarantine versus controlled monitoring. Any other questions? Okay, and like I said, if you have a question that you'd like to ask, but you just don't want to come up to the microphone, you're welcome to stay afterwards and come on up and see me or anybody here, and we'll try to answer your question. Okay, sir? This is Major General Dahl.
Thank you. So on behalf of Lieutenant General Lanza, Command Sergeant Major Norman from 1st Corps, I just want to let you know that we've been working on this for a few weeks now. Lots of staff effort, a lot of professional effort that's gone into this. I just was out at the facility. Should we be given the opportunity to host some of these folks coming back for controlled monitoring? I just went out and walked through it with Command Sergeant Major Norman, FORSCOM G4, Colonel Kumashiro, Colonel Shiki, a number of other folks, and it's a world-class operation. So we have a lot of capability here at Joint Base Lewis McChord, and I think you know that. I've got great confidence in the professionals that have put all this together, and I think that you can rest assured that we'll do it, and we'll do it well. It is a very, very low risk. In fact, while I was out there, it occurred to me that we are being very, very conservative in this. It's very, very low risk. So I was asking more questions about, let's make sure that these people are comfortable while they're here. So they have Wi-Fi, and they got MWR facilities, and they can work out, and they can train, and there's a DFAC, and they have access to all the normal things. If you are a reservist or a National Guard person coming back from a deployment, this would look just like demobbing when you got home. Yes, you're not going to go home to your family for 21 days, but that's what happens when you're from the Minnesota National Guard, for example, and you come from Minnesota to North Fort and you mobilize and you deploy to Iraq or Afghanistan for a year. And then when you come back, you don't get to go right back to Minnesota. You have to demob at North Fort, and then a couple weeks later, you finally make it home. So it'll be very, very similar to that. It's fairly routine. All the people who are involved in this is stuff that we do every day. It's just a matter of putting it together and being prepared. And I think, I don't want to say that it's unlikely that we'll get the opportunity to do this, but as was mentioned, there's 4 or 5 other sites that are a higher priority than we are, to receive folks coming in. But we'll be able to handle this without too much trouble at all. So I'm very confident. I think you ought to be as well. So one last shot for questions. Please share, as was mentioned, share with anybody else who, there's only one last opportunity to come to a town hall, so let them know it's 1300 tomorrow here. General Lanza will be here for that one, and that's it. So enjoy your dinner.